Good morning, everyone. So my topic is RNFL and ganglion cell thickness as an early marker for diabetic retinopathy. So my aim was to evaluate a diagnostic test which can detect changes in the neurosensory retina and serve as a biomarker to identify the patients as a risk of developing diabetic retinopathy, and to establish the role of OCT in evaluating the RNFL and GCC, which is the ganglion cell complex thickness, in diabetics without any retinopathy, and comparing it with their age-matched normals. So this was conducted as a tertiary care hospital in the Department of Ophthalmology, a cross-sectional observation study in which OCT ONH RNFL and OCT macular cube was conducted for both eyes of patients with diabetic mellitus, but no diabetic retinopathy changes, and their age-matched normals, that is, they had no diabetes. The ganglion cell complex and the RNFL was compared, and it is a cross-sectional observational study. It was for a 6 months duration, and the population was, as I said, diabetic and non-diabetics. The inclusion criteria were age more than 30 years, patient with type 2 diabetes without diabetic retinopathy. Exclusion criteria were any systemic disease other than diabetes, diabetic retinopathy or any other retinal pathology, previous laser photocoagulations or any injections, history of ocular trauma, high myopes, blurred ocular media, or glaucoma, which was an intraocular pressure more than 21 millimeters of mercury. So how we went about was every patient that came into the OPD, if we could fit into the inclusion and exclusion criteria, BCVA slit lamp, applanation tonometry, and a dilated fundus evaluation was done. OCT was done, and then they were divided into groups based on their blood. We got their blood investigations done, and then we decided whether they are diabetic or non-diabetic. Because many patients that come to our OPD, they are not aware that they are diabetics at all, and then their matching and analysis was done. These are the OCT scans showing the RNFL in the 4 sectors and GCC in the 6 sectors. So what we found was the RNFL in the 2 groups, in the diabetics and the non-diabetic, had significant difference. This RNFL is parapapillary and it is not macular. Where in the parapapillary also we saw that there was a significant difference, and the comparison was done by independent t-test, and there was the p-value was less than 0.001. As even can be seen in the graph comparatively, where the above graph is of the diabetics and the below one is of non-diabetics. Even similarly in the ganglion cell complex, in all the 6 sectors, it was seen that there was significant difference between diabetics and non-diabetics. We included 220 patients, 110 in each group, and they were all gender matched also. There were equal number of females and males. So as per the above, we deduced from a study that there is a significant difference in the RNFL in all sectors in age and gender matched diabetics and non-diabetics. Similar studies were conducted by Afif et al. And Pekel et al. And even they found that there was significant difference, but they found that there was, like in the Pekel study, there was significant difference in RFL only in the superior and the nasal quadrant. And the Malif study, they found that there was a significant difference in the average, superior and inferior. They did not find much significant difference in the nasal and temporal. Similarly, in the ganglion cell complex, there was a significant difference in both, but in the one study they found that there was only a difference in superior nasal, and the other that was found that there was significantly decreased in all 4 sectors. So in conclusion, the exact cause of this thinning in GCC and RNFL is still not known, but it seems to be occurring due to lower perfusion and higher demand of the inner retinal layers, which leads to these systemic changes. Another potential mechanism is the decreased availability of insulin, which is a survival factor for the retinal neurons, which is counteracting the apoptosis of the neuroglial cells in the inner retina, which induces which is inducing hyperglycemia and advanced glycation of the products. Hence, for early detection of diabetes-induced vasculopathy, rather than just dilated fundus evaluation, an OCT examination of the ganglion cell layer and the RNFL should be done. Thank you. We are looking forward to do this, their follow-ups after every year. So we'll come to know whether how early they are developing diabetic retinopathy.
Any, in which case you should do it in 2 segments, one which the diabetic control was good and in which it was not good?
Ma'am, no, we have done it in people who do not have diabetes at all. We did their FBS, PPBS and HbA1c of all the patients. So only in people who were confirmed non-diabetics were matched with people who were diabetics
No,
but
no, I
did not have.
understand. That is your current study. What
Yes,
you're saying
ma'am.
is in the follow-up, if you're planning to prove that it is diabetic retinopathy is related to the progressive thinning, then you
Yes,
have to have two subgroups where you can explain
Early
uh,
diabetics and
yes.
yes, ma'am.
And also whether your theory that it is ischemia which is causing a problem, then in which case the other corroborative
Factors have to be,
factors
yes, ma'am.
should also be looked at.
Thank you.